Hello, and welcome to the New Orleans VA. My name is Jean Cefalu, and I am a nurse practitioner practicing in geriatrics and extended care. It's my pleasure to present today geriatric syndromes. The term geriatric syndrome is used to describe the unique features of common health conditions seen in older adults that don't fit into discrete disease categories. Many of the geriatric syndromes share common features. The effect on the quality of life and disability of an older adult, though, is substantial when they have geriatric syndromes. In geriatric syndromes, the primary symptom or presenting symptom is not always related to the specific pathological condition, which challenges traditional ways of planning and delivering care. For instance, an older adult may present to the emergency room with altered mental status when what's actually going on is a urinary tract infection. Our objectives today is to discuss the prevalence and risk factors associated with falls, incontinence, frailty, nutritional problems, and sleep disorders in older adults. Identify key evaluations to differentiate the normal aging process from a reversible geriatric syndrome. And the last is to integrate geriatric specific evaluations into your discharge summaries to facilitate a safe transition of care between facilities. Two of the articles I posted are directly related to safe transitions of care, which is crucial for our older adults. Most of the problems they have seen, nothing's been addressed. No geriatric syndromes are really addressed in discharge summaries. It's just diagnosis and treatment. So in aging, there's the rule of fourths. Normal aging is only accounted for 25% of the problems with an individual. The other 25% can be accounted for disease, disuse or no use, and the other 25% is misuse. So when you see a patient, especially a geriatric patient, remember only 25% of what is going on is normal aging. And so this cartoon I've put in here sort of shows it. It says, going to the doctor and you say, I've got this pain in my knee, doc. And he says, well, it's old age. He said, but doctor, my right leg is just as old and it doesn't hurt it doesn't hurt at all. And that means that don't just pass off symptoms that your patient is giving you as signs of aging. It may be, but 75% of the time it's not. The geriatric syndromes we're going to discuss today include frailty, incontinence, falls, nutritional decline, and sleep disorders. The other topics will be covered in separate lectures. So our first syndrome, frailty, is interesting. Frailty has been defined as the inability to party all night long and is one of the earliest signs of aging. So I'm not making any judgments, but I want to say if you can't party all night long anymore, welcome to the club. You're starting into frailty. With increasing age and disability, diminished stamina can progress to the point where an older adult no longer has energy to complete his activities of daily living, which is getting up, cooking, eating, changing their clothes, brushing their teeth, taking a bath. This severe fatigue is a cardinal symptom of the frailty syndrome. The earliest manifestations of the frailty syndrome include weakness, a slowed walking speed, and decreased physical activity. I put the Jamar hand dynamometer on this slide because I had given a talk on frailty to a group of older nurses a few years ago, and I went into how to detect whether somebody is frail, and I found the physical therapist use this dynamometer to measure grip strength, and they have actually there is a list of how they measure it and what defines frailty. And of course, I was in number 3. I was in number 2, and I was only able to do about 9 kilograms on the grip strength, which would put me at frail. And that was a few years ago, so that was pretty disturbing to me. It might be interesting for you to go downstairs in the physical therapy department. They actually have these and try them on yourself. It's pretty interesting. There are several different scales published to measure frailty. One I like is called the Frail Scale. I like it because it's very short. It asks fatigue. Are you fatigued? And it's just yes or no. Can you climb a flight of stairs? Can you walk 1 block? If they have greater than 5 diagnoses, which I don't think I have any patients that have less than 5 diagnoses, and have you lost weight greater than 5% in the last 6 months? An answer to 3 or more of these is a definition, they can be diagnosed as frail. Functional decline is in the same category as frailty. And this is the rule of thirds. It has to do with hospitalized elders. 1 in 3 people admitted to the hospital older than 65 will have a functional decline from admission to discharge. This means something that they didn't have when they came in, but we're discharging with. In Louisiana, we call that lagniappe, but that's not a good thing. 1 in 3 will return to their prior level of function after discharge. 1 in 3 will be admitted to a nursing home, either for skilled care or for long-term care, and 1 in 3 of these patients will have died. And so some of the statistics are at least 50% of a new disability in an older adult is attributed to a prior hospitalization. The functional assessment is a crucial piece of information for an older adult. It may not be crucial in a younger person, but it is crucial when you get into geriatrics and palliative care. Function is everything. We're not going to cure most disease. Most elders have chronic diseases that we can't cure, but we can palliate, but we kind of judge how they're doing on their function. We always want to support independent function while in the hospital. And as I am a nurse, we are taught in nursing school to help people, and we want to help people. And unfortunately, what happens a lot of times is we help people too much and we make them dependent. We don't support independence. We're trying to help them do everything instead of waiting and seeing what they can do on their own. Please always recognize early ambulation is important. It is very important in your older adults. Get them up out of bed during the day. Order therapies. You're never too old for exercise or skilled therapies. The most preventative approach appears to be maintaining muscle mass and strength and consuming a Mediterranean diet to keep older adults healthy. Frailty predicts functional decline and the onset and progression of dependency towards the end of life. Severe frailty, a score of 4 or 5, combined with the metabolic abnormalities of low cholesterol and albumin, predict a particularly high short-term mortality rate in frail older adults. Case series suggests a poor response to treatment in those with end-stage frailty, meaning that they're not making any progress in physical occupational therapy or speech therapy. And at this point, it may be appropriate to consider palliative care consults. The next syndrome we're going to talk about today are falls. Falls are the leading cause of accidental death in older adults. 70% of all fall-related deaths in the United States occur in older adults. And about a third of adults over 65 years living in the community, just only 1/3, fall each year. If we could eliminate all falls, people would live a lot longer. Older adults greater than 75 years who fracture a hip as a result of the fall, over half of them will die within a year of the incident. Fall risk increases as we get older. Up to 50% of those greater than 80 years old will fall. 40% of nursing home admissions are attributed to falls and gait instability. A fall is not a normal sign of aging. A fall should always be treated as a symptom of something else. There should be a reason for the fall. It's interesting if you look at this chart that the highest percentage of falls comes from accidents or environmental hazards in the home. Why is this significant? Because these are throw rugs, absence of grab bars or modifications to the house, uneven floors, all things that can be modified to prevent falls. Here at the VA, we have a great physical therapy department, and if you put in a consult for a home safety evaluation, they will go out to the home and they will do evaluation with the veteran and make recommendations for modifications to the home to make it more safe. And if from 1 to 53% of falls, that have been recorded could be from accidents, environmentals, just think how many that we could prevent accidents in the home. Another one is gait and balance disorders. If you looked at the slide I had before, basically the use of assisted devices also can promote falls if they're not used correctly. This comes in to play when either somebody is not listening or paying attention to what they were taught, but also people with cognitive disabilities not remembering to use their walker or using something incorrectly. After an adult falls, the fear of falling can lead to social isolation, but it also can lead into a spiral of functional decline and acute illness. So this picture, and I hope you're not eating your lunch. I'm a wound care nurse, so it doesn't bother me. But this picture was taken at Interim Louisiana Hospital back in, I think it was 2010. And this was a patient of mine that I was admitted to the floor and I was consulted as. And during my discussion with her, I found that a few months earlier she had been admitted to the hospital because she'd fallen and she'd broken her hip. From there, she went to a nursing home for rehab and then back home with her daughter. And it was just her and her daughter, but her daughter had to work during the day. And this lady was so afraid of falling because she felt if she hurt herself again, she'd have to go into a nursing home, that she actually sat in her wheelchair all day long waiting for her daughter to come home before she'd attempt to go to the bathroom. And because of that, she was incontinent and she got a pressure ulcer and she didn't tell her daughter about it. And you can kind of see how bad it's already in. She was actually stuffing things in it just to sop up because she said it started to smell. Unfortunately, she started to get a fever and she had to come into the ER and she was admitted, and this was the end result. The bad part about this is about 6 months later, this lady died. Once it was debrided, she had a wound that basically would never heal and just got repeated infections, and she ended up dying. Preventing falls and functional decline is exercise, exercise, exercise. Move it or lose it. Maintaining physical activity and that muscle mass is critical in older adults at risk of being frail. There's resistance training, Tai Chi, anything that you can think of to get them interested in moving. Walking is great. Any other, swimming is wonderful, but preventing immobility is critical. So I want you to think prehabilitation, not rehabilitation. When you see a patient in the clinic, we need to encourage that ambulation, that exercise strenuously every single time that they come in. Otherwise, they're going to fall, and then you're going to be in rehabilitation. The next geriatric syndrome I want to talk about is urinary incontinence. This is one that's pretty special to me. I'm an ostomy nurse, but I'm also a continence nurse, and making people continent that haven't been continent is always, to me, very, very rewarding. Less than half the people with symptoms of urinary incontinence seek treatment because it's not a specific disease state, and people are embarrassed, and also people, they don't like talking about it to their doctor. So when you're interviewing older adults, it's very important to ask these questions. If you give them the permission to talk about it, they will. 15 to 30% of older adults in the community are affected by urinary incontinence, and up to 70% of nursing home residents have urinary incontinence, with another 30% also experiencing fecal incontinence. And urinary incontinence is one of the big things that makes family move their older relatives into a nursing home, because it might be cute when you're a little baby to be incontinent, but it's not cute when you're an adult. Urinary incontinence is twice as prevalent in older women than older men, and it is an extreme cost to the community. $7 billion business annually, and $3.3 billion annually is spent on urinary incontinence products in long-term care facilities. Although urinary incontinence is more common in older age, it's not a normal part of aging, and many people go their entire lives without being fecal or urinary incontinent. So if you want to think of something that can be reversed, transient urinary incontinence, think of drip. Okay, delirium. When people are delirious, they can't think to go to the bathroom, they can't process to go to the bathroom, they could be incontinent from that. R for retention or restricted mobility. If they're urinary retention from BPH or a stroke, something like that, these things are something that can be dealt with, medications, or hopefully they resolve. Some of their people who have a stroke will have urinary retention, but it will resolve. It just has to be monitored. Restricted mobility, adaptation aids, a closer bathroom, a raised toilet seat, clothing adaptations to help them get to the bathroom and get their pants down easier than all the buttons and zippers, or people with manual dexterity problems is important. Remember, fecal impaction. People become incontinent because if your rectum is full of feces, it's taking up all the room in your abdomen, and that bladder doesn't have time to have enough room to expand. That can cause overflow incontinence. And then P is for polyuria and pharmacologic reasons. If you're hyperglycemic, you're going to urinate more, which can lead to urinary incontinence. And of course, many of our older adults are on diuretics, and that can lead to urinary incontinence too. With somebody that's got established urinary incontinence, there are a lot of things that we can do. The first, urge incontinence, is the I gotta go, I gotta go. It's the subject of many commercials around 5 o'clock when you have the pipe lady and her little dog talking about, oh, they can't make it to the bathroom. These people, when they plan out a trip, a car trip anywhere, one thing they're going to do is map out all the clean bathrooms along the way, and they will know exactly how long it takes to get there. They actually have an app for that, finding bathrooms, because they'll also comment that they're, if they're clean or not. So for urge incontinence, what we do is we try and progressively increase the voiding time, trying to re-stretch out the bladder and make it hold more urine. There's also medications with that, but again, any medication, most of them are anticholinergic, so they have side effects with them. Stress incontinence is for runners, weightlifters, and women that have had a lot of children. Basically, it is just low tone in the pelvic floor, comes after having children, and these can be helped very greatly by Kegel exercises. Unfortunately, people will do the exercises and they'll gain their continence back, and then it'll get a little more incontinent next time, and they won't do the exercises. But that is something, a stress incontinence is something that you can laugh, cough, sneeze, and or pick up heavy weights and you have incontinence. This is something that be done with Kegel exercises. Now, overflow incontinence comes from strokes, BPH. This is a little bit more hard to treat, but it is very treatable. It can be treatable, and it's something that needs to be done. Just we don't leave this by itself. Remember, the bladder is a low pressure system, and if it's full, the urine is going to back up into the kidneys, and it's going to create more problems. So this is the most dangerous one. And then there's functional incontinence. And functional incontinence means you can't get to the bathroom. Something's preventing you from getting to the bathroom. It could be delirium preventing you to get to the bathroom. It could be mobility problems preventing you to get to the bathroom. It could be clothes that you can't get off in time preventing you to get to the bathroom. If I tied you in your chair overnight, you'd probably have functional incontinence. I'd like to do a subset of functional incontinence and make that forced incontinence. And the forced incontinence is where people are in the nursing home and the aides can't get to them in time and they become incontinent. Or they ask to go to the bathroom and they're told, well, just go in the diaper. You got that there, just go in the diaper. And I want you to think how you would feel, or I would feel, about somebody telling me to go to the bathroom in a diaper. And don't think it doesn't still happen. As much as we try, I had a patient in my clinic the other week A gentleman, he was 97 years old, and he had fallen, and he was in the nursing home for rehab, and I asked him, he was in a brief, and I said, well, when, and I started asking the questions, when did you become incontinent? He goes, I'm not. They just tell me to go in the diaper, and I do. Very, very sad. And then the last one is mixed incontinence. Mixed incontinence is because you have a lot of people with urge and stress, urge and overflow, or stress functional that you can't really tell. So try and narrow it down to see what exactly the symptoms are, when it started, what have they tried, and you can probably figure out exactly what type of incontinence it is, which will direct your management. So the next syndrome I'd like to talk about is nutritional decline. So data from a lot of studies of acute hospitalizations show that up to 71% are at nutritional risk or come into the hospital malnourished. Malnutrition, of course, is associated with increased mortality risk. Involuntary weight loss may be driven by a lot of factors: inadequate dietary intake, anorexia, appetite loss from multiple issues. It could be constipation causing appetite loss, disuse or muscle atrophy, which is sarcopenia, or inflammatory effects of disease. And how many of our patients have multiple chronic conditions? They all contribute to inflammatory cytokines and the effects of chronic disease. So some of the physiological changes of aging that are normal are decreased taste and smell sensitivity. After the age of 70, you lose about half. I don't know if you lose them, but you have senescence of about half of your taste buds. And this causes older adults, not to smell smoke, but it also causes them to add more salt to their foods so that they can taste. So what happens if you can't taste? If you were eating cardboard, would you really be hungry? Right. I don't think so. But if they can't taste it and we put them on a low salt diet, low cholesterol diet, what do you think? You think they're going to enjoy their meals? Absolutely not. Also, early satiety is related to the production and sensitivity of several digestive hormones. It goes down as normal in older age. And then a lot of older people, the older you get, you're prone to more dental issues. And because of money and finances, some people aren't able to afford dentures. What we see here a lot is they have dentures, but the dentures no longer fit. I don't know if you know this, but if you take your dentures out for a couple weeks, it's very hard to get them back in because your gums swell. So they have to be consistent with the use of their dentures. And if they're out or they're left at home during a hospitalization, that's going to pose a problem. So common causes of malnutrition in older adults, you can think Meals on Wheels. This was excellent. It was done by the St. Louis University Geriatric evaluation team, and they have a screening tool. It's called Meals on Wheels. It's easy to remember. M is medications. The more medications you take, if I've seen sometimes at 5 o'clock pill pass, that whole cup is filled up. That's their entire dinner. If you eat a whole cup of vitamins and pills at dinner time, do you really have room for anything else? Get rid of the excess medications, and you're going to see that their nutritional status is going to go up. Emotional problems, depression, loneliness. People don't eat a lot if they're lonely and they're living by themselves. Anorexia, it could be from nerves, it could be depression, it could be just from not eating in a long time. Once an older adult hasn't eaten in a long time or that diet has declined, you can't just feed them. You have to actually expand that stomach. You have to give multiple feedings, like every 2 hours, every 3 hours, and every 4 hours, little things to start expanding. You have to actually get their appetite back. L is for late life paranoia or alcohol abuse, which is very prevalent in our older adults. We don't want to think about it, who would be bringing them in alcohol, but they get it. S is swallowing disorders. Oral problems, definitely with teeth and dentures, multiple cavities. If your mouth is sore and you have an infection in any of your gums or gingivitis, you're not going to want to eat. So always check the mouth and to talk about oral problems and see if there's something we can do. N is for no money. And some people use their money to buy their medicines and not their food. W is for wandering. If somebody has malnutrition, if they have dementia and they're wandering and they don't remember to eat, that's very significant. And then at that point, they're going to need care, at least 24-hour care, to make sure that they are eating. They have to be redirected and watched while they're eating. H is for hyperthyroidism or hyperparathyroidism. E is for entry problems or malabsorption. Either they can't get the food into their mouth or chew it, or they're not absorbing anymore. E is for eating problems. These are the people with severe tremors, stroke, weakness, where they can't get the utensils in, cut their food, or get it to their mouth. And L is, like I said, low salt and low cholesterol diets, malnutrition. People won't eat. If it's not palatable, you're not going to want to eat it. So that's a big challenge to us when we have all these heart failure patients on our floors that on low salt diets, and then they're low cholesterol because we want to save their heart, but they're not going to eat, so they're going to die anyway of malnutrition. We can give them a little bit of salt. Sometimes you have to give them a little bit more Lasix, but give them a little bit more salt. And S is for shopping and food preparation problems. The more debilitated an older adult is, or problems getting around, they might not be able to go shopping. So if things are delivered to them, if it's Meals on Wheels, it's one thing, but the Meals on Wheels also are not geared to people that have low salt and, and special diets. I think they have some, but depending on where you are, everyone's going to get the same thing. Food preparation problems, we see a lot of older adults using the ready-to-heat meals. My parents are the same way. They have their they think they're on a diet, so they get lean cuisine, but these have a lot of salt and a lot of preservatives in them, and this also can contribute to malnutrition. Now, when you have malnutrition on top of dementia, like I said, if they're wandering, they really need some supervision to make sure that they eat and keep them on task. But the most common cause of death in dementia is pneumonia, followed by ischemic heart disease. 40% die of pneumonia as a natural cause and progression of that disease. Like I said, 86 will develop eating problems. They'll either refuse to eat, they're not hungry, depression, disinterest. They have difficulty with motor movement, getting things to their mouth, or they have dysphagia. The last geriatric syndrome I'd like to talk about today is sleep disorders. Up to 50% of older adults, even younger than 65, have some type of sleep complaint. 30% have chronic sleep problems. It's very, very prevalent. There is normal age-related changes that are related to this, and some they're not. Up to half of older adults use something to help them sleep. And then I want to say about 90% of families of older adults, especially with dementia living at home, are begging me to give them something to make them sleep. Rates of sleep disturbance in inpatient long-term care is much higher if you think about it. All the noise in long-term care, even when we try our best to be quiet, the carts rolling across the room, that will anything like that would wake me up, especially women. I wake up at the drop of a hat. I can imagine people inpatient with the noise and the talking and things going out in the hall, or people even just coming in the room, just opening the door to check on them and make sure they're okay, can disturb sleep. Older adults with obstructive sleep apnea may not be fat. They may not be obese. They may not have a big, large neck circumference. They could look normal. They could still have obstructive sleep apnea. So these are things that early on can be mitigated by getting them a sleep test. So some of the normal age-related sleep changes are less of a sleep drive. You're more sensitive to noises and unfamiliar surroundings. A hospital is definitely an unfamiliar surrounding. Sensitivity to noises. When you're older, you're a little bit more scared because when you're young and you're strong, you can defend yourself. A lot of older adults, the older you get, you can't defend yourself anymore. You might have everything locked up, but you don't have that bravado to think, I'm going to take on somebody coming into the house. So a lot of times this disturbs sleep. One little noise and they're up all night. There's increased napping as you get older because you're not sleeping at night. You're going to bed earlier. Most older adults, the circadian rhythm changes, and basically they fall asleep earlier, but they're up. I hear the common complaint, 2 o'clock in the morning, they're up for the day. You can't drug your circadian rhythm. You can try different things of getting exercise, being up during the day, lights on, Shades open during the day, activity, activity, activity. Sometimes adult day health care helps. They'll go to a center, senior citizen center, something to keep them up and not isolated. Isolation is the worst thing as an older adult. That actually goes back to eating also. They have shown that people that eat in congregation, that come out to eat, they actually eat more. And their nutrition improves when they're eating in a group setting instead of sitting alone in their room. So in the CLC here, we do that. We have everyone out unless they completely refuse. We try and get them to sit in groups as in congregate and eat. And this is the same thing at home. Some people won't eat, but if somebody comes over and eats with them, they will eat. Anyway, back to sleep changes. Basically, there's increased napping just because their circadian rhythm is off, okay? If you can avert that by exercise, daily activities, try and keep them up, try and keep them engaged, keep them doing things instead of sitting in the recliner, things can improve. It takes a long time for people to fall asleep. That increases with age, and there's a number of arousals. Just think about people that get up to the bathroom. I mean, it's normal for an older adult to get up 2 times a night. That is not nocturia. It's only when it's 3 and 4 and 5 times a night. So 2 times a night, it's not nocturia. It's a normal age-related change. And this circadian rhythm, again, there's less melatonin, and that kind of brings us to one of our first things that we do is probably give them melatonin at night and see if that would help with sleep. So I think I actually talked about treatment for sleep disorders along with the first slide. I apologize. But the biggest thing is good sleep hygiene. It is the most important intervention. TV off at night. I have people, though, that sleep. I have to say myself, I watch TV before I go to sleep. But the TV should be off at night. The bedroom should be just be for sleeping. With that said, I'll just leave it there. Keep them up and keep them busy during the day. Evaluate the medications. Make sure pain's well controlled. People can't sleep at night if every time they turn it really hurts. I'm saying that without opioids, but see if pain medicine at night before you go to sleep will help. And when I was a little nurse in 1984, it seems like it was yesterday, and I got out, massages, this is what we did to our patients at night, our last rounds. We had to offer a massage, just not a full body massage, but we did the neck and the back, and we rubbed the back really good. And it was extremely helpful. It's still extremely helpful, but we don't teach that anymore in nursing school, but these are some of the things that can be helpful, especially if you're in the clinic and you're talking to a spouse. Maybe that would help if they're having sleeping problems. Give them a nice, some warm milk and give them a little back rub. Just 5 minutes will do it. But if you have to give medications in the geriatric population, we have 3, melatonin, mirtazapine, and trazodone, that are safer. There are others that may be indicated if these don't work, but really, if they really give a good effort for the sleep hygiene, there isn't a pill for every ill, and you can kind of emphasize that with the patients. America, we are very much a pill for everything. Come in, this is your problem, here's your pill. And a lot of the things in older populations, for our older adults, aren't a pill for every ill. We need to get rid of some of those pills. So it's been my pleasure bringing you geriatric syndromes. I know this has been very short. Each one of these topics I could probably speak on a couple hours each, but I only had 30 minutes. Again, my name is Jean Cefalu. That's my email. My extension is 67154. I'd be happy to talk to you or get you any other information you'd like. And my office is on the 2nd floor, right above physical therapy in the M building and right downstairs from palliative care. I'm on the 2nd floor in room 105. Stop by anytime if you have any questions or you'd like further information. Here's a partial list of my references. If you would like full references, please just let me know and I'll be happy to give them to you.